Well, hey, everybody, this is Robert, and welcome to today's show. Well, November is C. diff Awareness Month, and the Peggy Lillis Foundation is out there leading the charge in building awareness by educating the public, empowering advocates, and shaping policy. So joining me today to talk about Clostridioides difficile, C. diff Awareness Month, and the work of the Peggy Lillis Foundation is Daniel Freedberg, MD. Dr. Freedberg is an assistant professor with the Department of Medicine, the School of Medicine, and Department of Epidemiology at the Mailman School of Public Health at Columbia. And Christian John Lillis. Christian's the executive director of the Peggy Lillis Foundation and her eldest son. I want to go ahead and welcome both you to the show. Good afternoon. How y'all doing?
Very good. Thanks for.
And I really appreciate you taking the time to talk about this really important issue. But before I get into the disease itself and the advocacy, I want to go ahead and just have you each talk a little about why you think the C. diff awareness month is very important. Christian, you want to start?
Sure. So despite causing over 500,000 infections and upwards of 30,000 deaths just in the US every year, C. diff is a very underappreciated and understood, but underappreciated infectious disease here in the United States and globally, with only about 30% of Americans having heard of C. diff. Now, in contrast to that, about 86% of Americans have heard of Ebola. And the likelihood of an American getting Ebola is vanishingly small. But C. diff, on the other hand, is the 17th leading cause of death for people over 65. And between the infections and the deaths, it costs our healthcare system over $5 billion in excess costs. And another reason to want people to be aware is that if you're not aware of something, you can't take steps to prevent it. So, you know, we go for colonoscopies, we go for, you know, women go for mammograms, like we do the things to help prevent cancer and other diseases. And if you haven't heard of a disease, you can't take those preventative steps.
Yeah, if I can add to that, Bob, I would say, you know, C. diff around the world, in the developing world, that parasites are the most common cause of infectious diarrhea. But here in the developed world, in the US or in Europe or in Canada, C. diff is the most common cause of serious diarrhea. So diarrhea that requires hospitalization, diarrhea that occurs in the hospitalization. C. diff is number one. It's really, you know, it's the main sort of diarrhea problem of the developed world, a problem that's closely related to use of antibiotics.
So, Dr. Freedberg, let's go ahead and do a little primer on Clostridioides difficile and the infection. What is it? And Christian's already talked about how common it is, but if you want to elaborate on that at all, because that's very significant.
Sure. So C. diff is, it causes diarrhea, and it is a bacteria, an organism that lives all around us. It lives in the soil, it lives on surfaces. It exists in a spore form, so it's very difficult to clean. To get rid of off surfaces, you need to use bleach or some kind of specialized cleaner. And in people who are susceptible, C. diff takes hold of the gut bacteria. And although the gut bacteria normally are diverse with lots of different bacteria, C. diff outgrows its normal niche and it becomes all of the gut bacteria. It just takes over the whole gut and causes inflammation in the colon and you know, a very troublesome diarrhea.
So now, as far as it being common, I mean, how do you compare C. diff to other diarrheal diseases or gastrointestinal diseses?
Well, you know, in the U.S., a lot of most diarrheal diseases are viruses, not COVID, but other viruses, and usually those aren't diagnosed. So people get them, they're sick for a couple days, and then they get better. They don't need any specific treatment. They don't have any specific treatment available. So we don't measure those. So we don't know exactly how common they are. But diarrheal illnesses that require hospitalization, C. diff is number one.
Sure. So who's most at risk for C. diff infection, and what aspects increase the risk?
Yeah, it's an interesting question, because even though C. diff is often perceived of as a sort of a bad bacteria, one of the interesting things about C. diff is that the bacteria is very common. Most of us are probably exposed to C. diff, from time to time, and yet we don't get sick. So really, C. diff is probably better understood as in part a host problem, that there's some reason why some people get C. diff and others don't. But we don't understand all of those reasons. We understand some. Some of the risk factors are things like being older. So older people are more susceptible to C. diff. Being immunosuppressed, like if you've had a solid organ transplant or have cancer and are getting chemotherapy or are on other kind of immunosuppressive drugs. Those are established risk factors for C. diff. But then there's also risk factors that we don't fully understand. Some people have a gut microbiome that's weaker than others, that's less good at resisting the expansion of pathogenic bacteria like C. diff. And that might be the most important risk factor, but it's not one we can really easily measure. We don't know how to tell a sort of a strong or resilient microbiome from one that's weak.
Yeah. Years and years ago, when I used to work in a clinical lab, it was generally considered an inpatient condition, inpatient disease. Is that still true today?
About half of C. diff is now community acquired, meaning it arises in the community.
So what's the symptomology? If somebody has C. diff, how do they present?
The presentation is usually diarrhea. It's a non-bloody diarrhea, so watery, medium volume diarrhea with a lot of urgency and frequency. So people using the bathroom 10 times a day. Later, there can sometimes be some minor bleeding, but that's not a big feature of C. diff. Some people can sort of last in that state for a long time, where it's this kind of persistent problem. They're outpatients, they're ambulatory, they're still eating and drinking. They're getting by, but they're probably miserable. But other people get even sicker, and they have a big inflammatory response. They can have temperatures, abdominal pain, a lot of inflammation in the colon, and that can be very serious. They need to be hospitalized, and they can get very sick and even die.
What is pseudomembranous colitis?
So that's a little bit more of an older term for C. diff that refers to what C. diff looks like if you do a colonoscopy.
Gotcha.
We don't normally rush to do a colonoscopy on people with C. diff because we have other ways of diagnosing it. But if you do a colonoscopy and you look at the colon, what you see are these things called pseudomembranes. They look like whitish or yellowish kind of plaques. And what they are the skin, the epithelial cells that line the colon. The colon is turning over. Those cells are being damaged. They're regenerating. New cells are forming. And the sloughed skin forms these kind of yellowish plaques. And those are what's called the pseudomembranes.
Gotcha. Now, I understand that C. diff has a habit of recurrence. You get it taken care of and it comes back. Why is that?
Yeah, so most people with C. diff will get better. They get treated with anti-C. diff antibiotics, and it's just a bad memory. But about 1 in 3 people will recur. It'll come back. And then of that 1 in 3, once you've had one recurrence, you're at risk for another. So now about 50% of those will have another recurrence. And the numbers keep getting worse. The more recurrences you have, the more likely it is to recur again. One of the reasons it comes back is related to the organism, that it's a spore former, and the spores are almost impossible to kill.
Right.
So even though you've killed the active form of the bacteria, the one that's causing diarrhea, the spores are still hanging around. And you get better, the symptoms go away, but the moment the anti-C. diff antibiotics are stopped, the spores germinate and the diarrhea comes back. So that's one reason. The second reason, though, is related to the host and going back to the microbiome, that some people have a gut bacteria, a native gut bacteria that just can't resist C. diff. And whatever it is about the weakness in that bacteria, they just keep getting it. They keep getting it. And if you look at the genetics of the C. diff in these people, what you find is that they're not just getting the same infection, meaning the same clone, the daughter or son spore of that first spore that they had, but it's actually a new organism. They're actually reacquiring it from the environment and getting it again. And that kind of speaks to how common C. diff is in the environment.
Sure. You talked about antibiotics used for the treatment of C. diff. And of course, when I've talked to people in the past, there's a lot of irony there, right? Because it's the cause is frequently because of antibiotic use. Can you explain what happens with this antibiotic associated type of colitis? I mean, and what that does to the microbiome?
Yes, it is ironic. I agree. And most physicians like myself feel like it's very unsatisfying to be treating this problem that's fundamentally related to antibiotics, or often related to antibiotics, with more antibiotics. The reason some antibiotics are a risk for C. diff is that they kill the other bacteria, the non-C. diff bacteria. So they open up a space for it to grow. Yet we treat C. diff with anti-C. diff antibiotics. Those are ones that affect C. diff more than they affect everything else. Now, those aren't antibiotics that are necessarily good for your gut bacteria, but they are better at killing C. diff than they are at killing other things. Vancomycin is the mainstay of treatment for C. diff.
And what are your thoughts on fecal transplants? That's become, at least from what my readings, pretty successful over the years.
Yes, so fecal transplant does work. The guidelines say that it can be considered after 3 occurrences of C. diff, or in cases of very severe C. diff. Fecal transplant has some logistical considerations and some downsides, because you are putting in new bacteria, and there might be some risks associated with that. But it does tend to work pretty well, has a greater than 90% success rate. But it's not first-line treatment, in part because 2/3 of people are cured simply with vancomycin, and that's a lot easier.
Yeah. How about diagnosis? Is this just like a simple lab test now?
Well, C. diff is a clinical diagnosis. There is a lab test, which is a stool-based PCR. The stool PCR doesn't miss a lot of cases, but some people are colonized with C. diff. So some people have C. diff in their gut, but they're not really infected. It's just sitting there in spore form, not doing much. So still, you need to make, as a physician, a clinical decision as to whether the lab test fits with the clinical scenario. So it's a combination of testing, stool-based testing, and what's going on with the patient.
So what are the best preventive measures?
Avoid antibiotics.
Stay out of the hospital.
Avoid antibiotics, stay out of the hospital, stay healthy,
yeah,
and clean your hands.
Yeah, good, very good advice. That's for a lot of different organisms. Christian, I want to switch gears over to you, and of course, Peggy Lillis was your mom, and I was wondering if you'd be okay sharing her story with the audience.
Yeah, absolutely. So my mother, Peggy, was a 56-year-old kindergarten teacher and single mother for most of mine and my brother's life. And she was, by all accounts, a really extraordinary person. Our parents split up when I was 5 and my brother was 2. And with the help of her extended family, my mom went from being a waitress on welfare to becoming a kindergarten teacher. She put me through college. She helped my brother become a plumber for the city. And just a couple of, she was also a very funny person, very lighthearted, but also kind of tough. I think you have to be tough to do what she did. But just to give you a sense of how well liked she was, when she passed away, she had 13 godchildren, and half of them were not related to us by blood anyway. So she was teaching. Her and my brother had recently bought a house together, and she went to the dentist, her longtime dentist, for a root canal. And as was common practice, so this is changing, she was given a course of clindamycin to prevent her from getting an infection following the root canal. And about 4 or 5 days later, after this appointment, she's taking the antibiotics. She woke up at 3 or 4 in the morning with very urgent diarrhea. She didn't think much of it. She assumed she ate something, or, you know, being around 24 5-year-olds all day, you know, 9 months out of the year, like, she would catch something despite being a healthy person. Like, she might get bad bronchitis one year, you know, but most of the time, you know, if she took a day off work, it was very unusual. So she didn't really think much of it. She just, like, you know, went to bed. That Saturday, when she still didn't feel better, she called her doctor. Without seeing her, and I'm sure Dr. Freedberg will be aghast at this, without seeing her, he prescribed her an antidiarrheal over the phone. And one of the challenges with C. diff is that in its process of reproducing, it gives off toxins. And those toxins are dangerous to our bodies. And that's part of what causes the inflammation, causes the diarrhea. And when you take something that prevents your body from expelling those toxins, you risk becoming sicker. But we didn't know any of this yet. So finally on Monday, when she still wasn't better, she called her doctor again. And the whole time my brother's checking on her, like bringing her soup, trying to make sure she's eating stuff. And she set an appointment to see a gastroenterologist. I agreed to take her, ironically, following my own dentist appointment with a different dentist. And when I got to the house, she just didn't seem like herself. And I knew enough about, you know, medicine and health just from being a hypochondriac, that I was concerned that she was just dehydrated. Like 4 or 5 days of diarrhea, really difficult to replenish your fluids. And I had worked at that point in healthcare in different capacities administratively. And so I said to her, I think we should just go to the ER. I think if we go to this GI appointment, they're just going to say you're dehydrated. We need to go to the ER. And so we did. And about an hour into us being in the ER, the attending for the ER and their infectious disease attending approached me and my aunt who had come to check things out. My aunt is a nurse. And they pulled us aside and told us that my mother had a life-threatening infection, that her white blood cell count was over 40,000, and that it was caused by something called C. diff. And I had never heard of this before. And my aunt, who was an oncology nurse, said, how could my sister have C. diff? She hasn't been hospitalized in decades. Like, and remember that this was in 2010. So it was a little over 11 years ago. So we got the family together. My brother came to the hospital, other family members. My mom had 8 siblings, so very big Irish Catholic family in Brooklyn. And so by that evening, I think there was 50 people in the waiting room, just different cousins, friends, whatever. And so, you know, as Dan said, they did a stool test. They actually did do an MRI, a CAT scan, and a colonoscopy to see if she was impacted. She was diagnosed with toxic megacolon, which is when, you know, the pseudomembranous colitis that we were talking about earlier kind of just really gets full, and your whole colon becomes like a toxic stew. And the funny thing is, despite all of this, when we were in the ER, and especially when she was starting to get rehydrated, she was herself. She was funny. She was mad that we wouldn't get her a Diet Pepsi, and you know, and that she could only have ice chips and stuff. But in order to do the colonoscopy and the CAT scan, because she was so ill, her vitals were so bad, they asked to intubate her, which we approved. And so that evening they said to us, were giving her vancomycin by IV. They were actually overnight, they gave her vancomycin enemas. They were giving her IV immunoglobulin, basically doing everything to just arrest what was quickly becoming septic shock. And they said to us, go home. We're going to continue this overnight. If anything goes south, we'll call you. If she improves overnight, we'll revisit our options in the morning. If she doesn't improve overnight, then we're going to want to do a colectomy in an attempt to save her life. And I think that's when just the gravity of the situation really began to hit us, that, you know, our mom, who had been so tough and so strong our entire lives, and who had, you know, dealt with a lot of difficulties, and come through all of them shining, that we might lose her. And so that night we went back to the house that she and my brother shared. There was lots of crying, there was lots of phone calls, there was lots of praying. And we went to sleep, and at 6 o'clock in the morning, my phone rang, and it was the surgeon saying that she really hadn't improved overnight, and they wanted to do the colectomy, and we had to meet at the hospital to approve it because she was intubated and couldn't sign for herself. So we went, they did the surgery. She came through with flying as best as it can be expected. I mean, they told us she might not even make it through the surgery. And throughout the late morning and early afternoon, her vitals got better. Things seemed to improve a bit. We went out and had some lunch. And when we came back around 4:30, they again pulled us aside and said that her blood wasn't oxygenating. And that her liver was shutting down, her kidneys were shutting down. And so for the next couple of hours, like 2 by 2, the incredible number of people who were assembled there took turns going in and sitting with her, talking to her, telling her she was strong, that she was tough, that she could beat this. And around 6:30, 2 of my aunts were in with her, and they basically asked them to step out so they could, you know, do something with my mom. And about 30 minutes later, the ICU attending came out and told us that my mother was gone, that they had tried 3 times to revive her. And ultimately her immediate cause of death was what they call disseminated intravascular coagulopathy, which means that her blood stopped clotting, and basically sepsis is what took her. And so she died on about 7:10 p.m. on Wednesday, April 21st of 2010.
Well, Christian, thanks for sharing that story. I know that takes a little bit of strength to do that. Dr. Freedberg, I want to piggyback on something that Christian said, though. She was at the dentist and received clindamycin. Is clindamycin one of these broad spectrum antibiotics that would wipe out the flora?
Yeah, so all antibiotics have different kinds of activity. Some work better against some bacteria than others. And clindamycin, the antibiotic that Christian's mom received, is the one that's most associated with C. diff. That the kind of bacteria that it kills seem to be those that best fight against C. diff. That's one of the reasons, you know, why awareness is so important, because physicians and dentists do have options with regard to antibiotics that we can, you know, choose. We have a lot of latitude in what we choose. And if people are cognizant of C. diff, we can choose ones that pose a lower risk of C. diff, might still have some of the same, you know, same benefits as far as killing the bad bacteria that we want them to kill.
Yeah, good point. Christian, so this obviously prompted you to start the Peggy Lillis Foundation. Can you talk more about the foundation and the important work that you do?
Yeah, so when so people ask me and my brother, they're like, why did you do this? And that's like, well, we couldn't not do it. We don't even remember actually agreeing to do it. It just, like my mom died in April, and then when we had our family picnic, our like cousins picnic in July, we already had invites printed for the first fundraiser. Like, I just think we were so devastated by how quickly she went. And, you know, the more that we dug into it, the more that we realized how many people we were losing to this every year. And for a variety of reasons, I'm sorry, there's a buzzing in the background. So for a variety of reasons, you know, there was no organization. We were the first. There was no one working on this issue. And so we decided that we had to do something about it. So, so initially we were really focused on awareness. I was working a different job full time. And, you know, in the early days, we began to realize how much this was needed. And so in 2014, we developed a new plan, and that brought us to our current mission. And our mission right now is about building a C. diff awareness and education movement nationwide, and doing that by educating the public. Again, you know, 70% of Americans haven't heard of this yet. Empowering survivors and caregivers, so people either like me or my brother who have lost a loved one, or maybe had a loved one be very ill, or themselves had survived C. diff. And with that combination of a more informed public and an active base of patient survivors and loved ones, really focusing on shaping policy. So that can be everything from, I was involved in the writing of the antibiotic stewardship playbook for hospitals. So giving a lens on like, how can hospitals help patients to understand that we have to use antibiotics more judiciously, and that it's not just, we're not being difficult. We want, we actually need to preserve these antibiotics, and that if you're using them unnecessarily, there are risks, and C. diff is one of those risks. And then there's also stuff like at the federal level, we have currently been working on, helping, I should say, that PLF is encouraging our people to advocate for a new law called the PASTOR Act. And that would help to create new antibiotics and new antimicrobials by basically delinking the payment of antibiotics from the volume of sales. So much in the same way that we've all gotten a free COVID shot, free COVID vaccines, this would basically make antibiotics free. It would make the US government the primary purchaser. And then we would be able to use, like a doctor like Dr. Freedberg would no longer have to worry, does somebody's insurance cover fidaxomicin versus vancomycin? They could choose what they thought was best for the patient. And at the same time, we don't have to worry about the companies that invest billions of dollars in developing these drugs not making enough money to justify developing them. So, and then in terms of public awareness, it is C. diff Awareness Month. And we are in the third year of a campaign we call See C. diff, SEE, like seeing something, See C. diff. And we're using that to raise awareness as much as possible. We've set a goal this year of reaching 1 million Americans with our message. And we are excited to say that we are about halfway through the month, and we're about halfway there. And that's why we're really glad that you invited us on the show. I'll mention one more thing, is that, when we talk to people, and I think Dr. Freedberg would agree with me here too, is that C. diff is a very isolating disease. Like when you have diarrhea 10 or 20 times a day, you're afraid to leave the house. People are afraid of giving it to their loved ones. They're ashamed because, poop is a kind of taboo topic in our culture. So they don't really want to talk about their symptoms. So we have about 30 people on our Advocates Council. And again, these are either family members or survivors. And they do a lot of media work. They do a lot of sharing their stories. but we annually have a summit in DC where we bring together experts, policymakers, and this group of advocates to learn, network with each other. And then since 2018, we have had the only C. diff lobby day, where we go to the Capitol and talk to all of our legislators. And that's been really cool and very interesting, but also a little depressing because none of them have ever heard of C. diff.
I knew you were, for some reason I knew you were going to say that.
Yeah, but it's been good because it really has it is given people who feel really traumatized, you know, like the thing about C. diff recurrence is that when you're experiencing it, it's like it's really emotionally and mentally distressing, right? And so people want something good to come out of their experience, and we provide them with that, with a venue for that to be true for them.
Yeah. One thing, when I had the website up on the camera, one of the sliders were saying to get C. diff infection to be designated as a U.S. nationally notifiable disease. I'd like you both to answer this question. Why is that important? Christian and then Dr. Freedberg.
So there's a couple of different forms of how infectious diseases, or even chronic diseases, but we're talking about infectious diseases here, how they end up being tracked, surveilled, and reported to the CDC or HHS, and then whether or not that information is made public, right? So currently, C. diff is one of the, currently C. diff is reported by hospitals, most hospitals, there are some exceptions, under the Centers for Medicare and Medicaid's conditions of participation. So if you're a hospital that takes Medicare and Medicaid, you have to adhere to these things. And one of them is that you have to report your C. diff cases. Unfortunately, that leaves out a lot of C. diff because acute care hospitals, meaning hospitals that I think don't have another hospital within 100 miles, are exempt. Children's hospitals are exempt. So, you know, when we say that C. diff is decreasing in hospitals, like, we're going by this data that we have. And Dr. Freedberg, I'm sure, has been part of this in his own hospital, but there has been some decrease in hospital-acquired C. diff. Theoretically, we think that that's mostly due to antibiotic stewardship programs where doctors are working to prescribe less antibiotics and use more narrow spectrum ones when they do. But the rates of community-acquired C. diff are the same. Honestly, they could be higher. Like, they're based on, like, these estimates are based on the Centers for Disease Control's. They have like 6 sites across the country that they feel are nationally representative. But, you know, it's like an algorithm. It's like, you know, it's a projection. It's an estimate. And so, you know, we think that community cases are the same, maybe getting a little bit higher, but we don't really know. And I think we should know.
Dr. Freedberg? Yeah,
I completely agree with everything that Christian said. We do have monitoring of C. diff. It's not that we don't study it or know something about how common it is and whether it's getting more or less common, but we don't know about all of it. And we patch together different sources of information to try to understand how it's being spread and how the things that we're changing are affecting it. But the more we can measure it, the more data we have, the better we're going to be able to tackle the problem. And this would help to make that possible.
Yeah. Let me go ahead and close with this last open-ended question. You know, there's so many different pieces of this puzzle and things we could talk about. So I just want to give you both an opportunity to talk about anything about C. diff or the efficacy that I may not have asked about and you think is worth covering. We'll start with Dr. Freedberg.
Well, I think we hit upon the main points. I guess, you know, if I were giving a final sort of takeaway for people who might be listening or watching and have never heard of C. diff before, I would urge them to be very careful consumers of antibiotics, because for better or for worse, physicians like me are really influenced a lot by patients. And, sometimes patients may push for antibiotics, not realizing that they have consequences or can have consequences. Other times, patients could ask, is that really necessary? Could I wait another day and see if it gets better? And maybe then start the antibiotic if I'm not getting any better. That's something to think about, something that people can do right now, tomorrow if they're sick.
Christian?
Well, I certainly agree with that. I think the other thing is, we are still in a pandemic. And I think that one of the things that COVID-19 has exposed is just how under-resourced and underfunded our public health system is. And, that lack of resources plays out in really dangerous ways, even when there's not a pandemic. Departments of health don't have the resources to educate their constituents about potentially dangerous infections. And so, they can't properly surveil for infectious diseases. And then, they're often unprepared to respond to outbreaks of communicable diseases, So one of the things that I hope now that we're in, I think, month 21 of this global pandemic is that this ordeal is going to make it clear that even in a place like the US, which is a pretty wealthy post-industrial country, that we're not exempt from infectious diseases. When you hear about people dying, it's cancer, it's heart disease, but if you tally them together, pneumonia, C. diff, MRSA, like the third leading cause of death in the US is infectious disease, but we don't think about it that way because it's all these different diseases, right? And I think that what we need is for the public to get involved in this, right? And to talk to their elected leaders, to ask questions at town halls, like, are you funding public health, and really get involved in something like trying to pass the PASTOR Act and other things that can help us to reinvigorate our public health system. There's been a lot of money going into it because of COVID, but we have to make sure that that money gets spent well. And also that, when COVID is no longer a crisis, they don't turn the tap off, because, one of the best defenses we have to everything from C. diff to COVID to other antibiotic-resistant infections is a strong public health system. And I don't think I fully appreciated that until I lost my mother.
Christian, if anybody wants to learn more about the foundation, where could they find you? Website, social media?
So you can visit us at peggyfoundation.org. If you want to get involved with the C. diff campaign, we got very lucky and managed to score cdiff.org. So that's really easy to remember. And if you want to follow us on social media, you can look us up on Facebook, but we're also pretty active on Twitter and Instagram under Peggy Fund, F-U-N-D, Peggy Fund.
Very good. Great work that your foundation is doing. And I wanted to thank you, Dr. Daniel Freedberg and Christian John Lillis, for sharing your time with me today and the audience. Very important stuff, and I'm glad that the information is getting out there.
Thank
you so much for having us, Robert.
You bet.